Hello, I'm Dr. Lo Ngai Nung from Singapore, and I must thank EDSO and the Philippines Hip and Knee Society for inviting me to participate in this virtual postgraduate course on knee replacement surgery. I will speak on the management of the severe valgus knee in knee replacement surgery. The usual osteoarthritic knee is in varus alignment because of the increased load over the medial compartment due to the adductor moment arm. So when we are faced with a valgus arthritic knee, it's important that we consider what would be the cause. Now, here are some secondary causes that will lead to lateral compartment overload, leading to osteoarthritis and valgus alignment. Rheumatoid arthritis is a common cause for the valgus knee. It is an inflammatory arthritis that causes erosive damage to the cartilage. The knee therefore can be in valgus, can be in varus, or can be in neutral alignment, or the patient often presenting with a windstrap deformity. This is a case of a valgus knee as a result of loss of overcorrection after the high tibial osteotomy. In this case, this is the lateral compartment wear as a result of malalignment arising from a tibia shaft fracture malunion. And then, of course, in valgus knees can be the result of leg length discrepancy as a result of hip pathology, or sometimes from a pelvic tilt arising from spinal pathology. So this is my approach to the valgus knee. Number one, we look for cause. Often we advise a long leg film or pelvic spine films to look for associated hip and knee pathology as the underlying cause for the valgus malalignment, and also to look for retained hardware as a result of previous surgeries. Number two is to assess the patient's soft tissue balance, and in particular to look at the medial collateral ligament to see whether it is functional or whether it is no longer competent, and whether we need to plan to use a constrained condylar implant. In this lecture, we will then talk about how we approach the bone cuts as well as the soft tissue releases in a controlled manner, so that at the end of the day, we finish up with a neutral aligned knee that is balanced through the range of motion. And of course, we talk about some known complications associated with the valgus knee. The anatomic features of the valgus osteoarthritic knee. We must be aware that in such a case, the lateral femoral condyles are often hypoplastic and worn down. The lateral soft tissue structures are often contracted and tight. The iliotibial band, the posterolateral capsule, the lateral collateral ligament, the popliteus tendon. And then on the corresponding medial side, the medial stabilizers are often attenuated and stretched out. The surgical approach to the valgus knee can be by the standard medial parapatellar approach, which is an approach that we are all very familiar with. Or we can also do it from a lateral approach. The advantage of the lateral approach being that we have direct access to the tight lateral structures for release. We preserve the blood supply, especially if we end up, when we do a medial parapatellar approach and we also have to do a lateral release, the potential for devascularization of the patella. In the lateral approach, because of the lateral approach, in fact, doing the patella release, we address the patella maltracking. But of course, a lateral approach is unfamiliar exposure to a lot of us, and it can make for a difficult soft tissue closure on the lateral side. Valgus knees can be graded, and this is a very easy and practical grading system by Professor Ranawat, published in JBJS in 2005. Less than 10 degrees, the MCL is all usually functional, and that accounts for 80% of the cases that we do. And the grade ones are often easy to balance. We can release the lateral structures to balance to the MCL, and we can usually do these cases with a standard total knee implant. The grade 2s from 10 to 20 degrees, the MCL is often lax, attenuated. They form 15% of the cases. More releases are necessary on the lateral side, and we have to be careful at times that we may end up not being able to balance. By the time we reach a grade 3, and that's more than 20 degrees valgus, the MCL invariably is non-functional, totally stretched out, lax, and this forms the last 5% of the cases. And these are the cases we need to be aware of, that we always have a constrained condylar implant ready, because it's often not possible to release the lateral side in order to balance to the non-functional medial side. Soft tissue balancing. This is the steps I use. Step 1, after we expose, we remove all the osteophytes on the lateral margins of the tibia and femur, and this releases the bowstringing effect of the lateral stabilizers. Then we start to do releases of the IT band, and this can be easily done off the Gerdy's tubercle with a diatomy, or by pie crust controlled lengthening of the IT band. By the time we hit step 3, and this usually, if the knee is still tight in extension, it will involve releases around the lateral margin of the tibia plateau, and normally we will sublux the tibia forward, use a diatomy, and release fully the capsule and soft tissue all around the lateral side of the tibial plateau down to the posterior lateral corner. Now, in this part, we must be careful because the common peroneal nerve runs in this lateral corner. This is an interesting study showing where we expect to find the common peroneal nerve in relation to the posterior lateral structures of the knee. And the nerve will be over this corner in the 30 to 55 degree angle to the anterior posterior axis of the tibial plateau, lying here just behind the popliteus tendon. So it's imperative that we do not put a direct blade release to the posterior lateral capsule, but instead we keep the diatomy onto the bony margin and slowly release the capsule of the bony margin. Lastly, once we have it adequately released in extension, we put the knee in flexion, and we can then test with laminar spreaders whether we have a balanced flexion gap. If the knee persists in being tight in flexion, then with the knee in flexion with a tensioners holding the knee apart, we then use a 15 blade to pie crust the lateral collateral ligament of the femoral attachment side. If it's still tight, then we next release the popliteus tendon in the posterior lateral corner carefully. The bone resections. The bony deformities of the severe valgus knee would be a very hypoplastic lateral femoral condyle, so much so that in the distal resection, often we end up with hardly any bone resected. And in flexion, we have to be careful that the hypoplastic lateral femoral condyle will result in us malrotating and undersizing the femoral component. So after the exposure, the first step, the distal valgus cut is often set at 3 to 4 degrees to prevent overstretching the attenuated medial stabilizers. We set 3 to 4 degrees in comparison to the normal 5 to 6 degrees that we normally set for a varus knee. You can see here the distal resection guides going into the IM canal, and often the severely hypoplastic lateral femoral component does not even come in contact with the resection guide, or just barely the resection skims and right across the hardened athletic surface of the lateral femoral condyle. After the distal resection is done, we will then mark the white side line and the transepicondylar axis. And this will then help us set the size as well as the rotation of the femoral condyle. If we use the pedals of the sizer as we normally do for a varus knee to size and set alignment, invariably the alignment will be wrong because of the severe loss of the cartilage and bone of the posterior condyles of the lateral femoral side. You can see in this intraoperative picture, the white side line being set against and perpendicular to it, the transepicondylar axis. So if we look at the transepicondylar axis in relation to the posterior condyles, you can see how hypoplastic and worn down the posterior condyles are. Hence, they no longer act as a reliable guide to setting rotation. At the end of the day, we should end up with rectangular extension gaps with the lateral soft tissue balanced to the medial soft tissue. And then in 90 degrees flexion, we should again have a rectangular flexion gap with the lateral soft tissues balanced to the medial soft tissues. With this, we trial our implants. We should be in neutral mechanical alignment in the coronal plane. We should have flexion extension gaps balanced to each other. The implants should be stable through the range of motion, with the collaterals offering stable varus valgus stability on varus valgus stress. And then lastly, as we range the knee to the motion, the patella should track satisfactorily. With that, we will have completed our surgery adequately. Sometimes we will find that we fail to achieve these objectives, and these are invariably in the Ranawat type 3, grade 3s, where because of the long-standing severe valgus knee, the medial collateral ligament is no longer functional, so badly laxed out that we can no longer release enough on the lateral side to get it to tense up to match on the medial side. So in such a scenario, we will then resort to a constrained condylar knee implant using the constrained post to provide us the stability to restrain the non-functional medial collateral ligament. The other reason to use a constrained condylar knee would be such that when the medial structures are so loose, such that in order to balance the lateral to medial, we have to do such a massive lateral release and use such a big piece of polyethylene to balance the gap, that we put the common coronal nerve at risk of stretching and then ending up with neuropraxia and a foot drop. So in such a scenario, again, it will be prudent to then use a constrained condylar knee to then hold the gaps stable using the constrained post instead of trying to balance against that non-functional medial collateral ligament. Sometimes in the Ranawat grade 2 knees, we find that at the end of our releases and bone cuts, we still have a mild asymmetric gap. Now, in these type of cases, we can often address the problem using a constrained posterior stabilized insert. These are mid-level constraints that will just provide us enough stability and yet act as an internal splint to hold that knee while the medial collateral ligament subsequently contractures and tighten up over time. And with this, we do not then need to use a full-blown constrained condylar knee with stem extensions. Results. Well, results of the valgus knee arthroplasty are usually reported to be poorer generally compared to the varus knees. And the reasons would be because of difficulty in balancing the soft tissue, often some asymmetric instabilities resulting after releases, sometimes because we are unfamiliar with the soft tissue approach, the releases and the approach, and at the end of the day, leaving the knee in a persistent malalignment. Here are some complication rates reported with the valgus TKR. Soft tissue instability, recurrent dislocation, 6 to 24%. Patellar maltracking because of malrotation, 0 to 4%. Peroneal nerve palsy because of stretch on the lateral side, 0 to 3%. Wound healing complications, especially with the lateral parapatellar approach, 1 to 10%, and inadequate releases resulting in a recurrent valgus deformity, 5 to 20%. So because of these various reasons, the revision rates have been reportedly somewhat higher than compared to the varus knees. So in conclusion, I would summarize again. Number one, always look for a cause. Do a careful clinical exam and history taking. Do long leg films. Ask for hip pathology, lumbar spine pathology. If we know the cause, then we can make sure we do not have residual deformity. Number two, assess the medial site structures, the MCL. Is it functional? Is it competent? Are we looking at a roundabout grade 1, grade 2 here? Do we need to stand by a constrained condylar knee? Number three, the bone cuts. Be conservative. Always be aware that the lateral condyle is hypoplastic and can affect your sizing and your rotation. And the medial condyle is often osteoporotic and with the potential for collapse and fracture. Releases. The lateral soft tissue releases to be done in a controlled sequential manner such that you can then match it to the medial side, and failing which, then of course to consider condylar, constrained condylar knees. At the end of the day, we must finish up with a well-balanced, well-aligned knee, and only then will we avoid all the complications that we mentioned in the previous studies. Last but not least, beware of the foot drop, the peroneal nerve. Always take care in your releases. If we find that we are unable to balance, then use a constraint. And at the end of the surgery, always send the patient out of the OR with the knee in flexion and rest the knee overnight in flexion until the next day when we see the patient again. Because the swelling, the tension through the night can even give you a foot drop after surgery from that. Thank you.